Digital transformation impacts quality, but its jargon can be overwhelming. I'm Andy Reynolds. On this episode of Quality Matters, we demystify key concepts of the digital transition using clear explanations and relatable examples. My tour guide is Ed Yurcisin, Chief Technology Officer at NCQA. Ed has a gift for metaphors and analogies that make abstract ideas vivid and relevant. An excellent companion resource to this conversation is NCQA's online digital hub. Search NCQA Digital Hub or NCQA Digital Transition in any browser or search engine. That'll come right up. Here is my conversation with Ed. Ed Yurcisin, Chief Technology Officer at NCQA. Thank you for coming on Quality Matters. It's good to see you.
Thank you, Andy. It's great to be here.
Let's start big picture. How can we best use information technology to measure and improve the quality of healthcare?
We want access to data so we can make good judgments and enable people to make good decisions on healthcare quality. So NCQA is trying to accomplish several things. First, it's the digitalization of measures. With our digital measures, we're trying to reduce waste and burden. We're trying to make these measures more accessible and ubiquitous, so these measures can be utilized by more people. Now, one of the challenges with that is data quality, which is how good is the data? There's a lot of dirty data in our healthcare system, not intentionally. This is entered by humans not having the time to enter data correctly, poor training.
Okay, so you've identified two big topics, digital measurement and the upstream or parallel issue of data quality. Let's tackle those one at a time. What problem does digital measurement address, and how is that going?
So HEDIS is the measure set at NCQA. It is a 1,100-page PDF in English. That's a lot of words to read. Words are open to interpretation. When you're implementing a HEDIS measure, you're reading English text. There could be gray introduced. There are about 90 HEDIS measures. We have digitalized 80. We have created specific logic in a language called Clinical Quality Language, CQL. This is a way to express in a logical format these 1,100-page PDFs and break it down so you can distinctly see this measure. Here are the logic constructs. Here is how we're processing the measure. So it's unambiguous. We've eliminated the gray area. And you no longer have to read these 10, 12, 15-page measures and try to really interpret nuance. By digitizing these measures, we've eliminated ambiguity in understanding and implementing HEDIS. So these measures can be utilized by more people.
Eliminating ambiguity sounds attractive in and of itself, but I imagine the clarity that produces also brings knock-on effects or a domino effect. What are those other benefits?
Absolutely. This is reducing variation. When you have all of these organizations reading our 1,100-page PDF, they may end up with different ways that they're coding these measures. And that leads to variation. We're trying to provide structure and eliminate a lot of the variation that occurs.
Okay, so digital measures means less ambiguity, less interpretation, and therefore less variation in how HEDIS is implemented. I do want to give you a chance to talk about data quality, but what else do people need to know about digital HEDIS?
Let me discuss FHIR, FHIR. It stands for Fast Healthcare Interoperability Resource, and it is a scary term for high school level computer science. It's web browser technology. It is the computer science used in virtually every web page.
Okay, I think I know where you're going with this, Ed. Let me offer my fellow English majors a mnemonic trick to track some technical terms here. That is, FHIR rhymes with 5. Keep thinking FHIR 5, FHIR 5. That'll remind you that FHIR has 5 key components or attributes. Okay, Ed, please continue.
You use the underpinnings of FHIR every day, something called JSON, and REST APIs. FHIR is REST APIs and JSON, which every web browser uses. My son is about to graduate from high school, and last year, as a junior, he was studying REST APIs and JSON. So very standard technology.
Okay, so you've given us two features of FHIR. First, JSON is essentially a labeling system to help computers organize information. Second, REST APIs are how computers convey and fulfill requests between each other, almost like a waiter is the go-between at a restaurant between the people who cook the food and the people who eat the food. Am I right so far?
Absolutely. Additionally, FHIR includes a specific data model from a technologist. Great, we're all going to use the same format, and very specific value sets. The value set is a way to codify some concept. An area code is a value set, zip codes are value sets, but rather than having somebody type in, for example, gender, male, or M, or did I capitalize it all? Did I spell it right? Value sets eliminate this and just give everything a code that can be selected.
Am I right in thinking of a value set as a pick list, that is a predetermined menu of valid values that represent something?
Absolutely.
Every time you go on Amazon to order a delivery to your house and you have to pick the 2-letter abbreviation for your state, that is a pick list.
That's a great example.
Okay, so REST APIs, JSON, data models, and value sets, otherwise known as pick lists. That's 4 elements of FHIR. I know you're excited about FHIR's 5th piece. What is that?
The last thing that FHIR is, it's mandated exchange. Payers move at the pace of mandates. They move and they adopt because the government requires something. There are incentives that the government has put in place. That's helped start the process. The government was looking at how data was being exchanged, and the government didn't want the healthcare system to invent a brand new way to do it. Instead of every health system or insurance company coming up with their own format and their own way of exchanging data, they decided to come up with essentially an industry standard. So they looked out and said, let's take an example from the web. And basically, FHIR is web technology. It was a great move. The government has required this to be how health insurance companies communicate with their beneficiaries, providers communicate with the patients, health systems communicate with insurance companies. They've mandated this ecosystem. The first Trump administration made it a requirement for Medicare Advantage and Medicaid plans to be able to communicate with beneficiaries using FHIR APIs. It's great to see standardization in the industry. One of the truly bipartisan areas of government is healthcare data exchange because it reduces burden, it reduces errors, it reduces inefficiency and waste.
I've heard you compare FHIR's mandated data exchange to baseball. What do you mean there?
If you think of FHIR in baseball terms, the government can require the pitching of FHIR data. They don't require the catching. The government is able to require organizations to provide the data, but they're not able to require organizations to use the data in their quality pipelines or care delivery or care management. They can't force the exposure, the exchange of the data.
That seems half-baked. What's the point of doing one without the other?
Well, government is looking for peer pressure. You create a strategic advantage by catching and utilizing the data. The government is requiring organizations to make the data available, but if one health plan starts using the data, they will have greater insight into their patients. They will be able to provide care more efficiently at a lower cost and higher quality. That gives them a leg up over organizations not utilizing the data.
We've been talking about FHIR, but there's also bulk FHIR. What is that and what's the difference?
FHIR by itself is for an individual, bulk FHIR. That's really population level FHIR. Think of it this way. If I'm going into ESPN looking for statistics, FHIR allows me to go into one particular player. I could go into Lamar Jackson's statistics. That's great. Bulk FHIR is designed to allow me to get that for a group of players. I could ask for everybody on the Baltimore Ravens. I could ask for all quarterbacks. I could ask for everybody in the NFL. These are different population level queries. It's different use cases. That's the difference between FHIR and bulk FHIR or population level FHIR.
You and your staff at NCQA are heading up something called the Bulk FHIR Quality Coalition. What is that? Who is it for? And what are you doing?
The Bulk FHIR Quality Coalition is one of the NCQA initiatives to help drive data quality. There was an initiative out of Boston Children's Hospital that was able to test the water pressure in this pipe that's of data exchange. It was a great initiative, but they failed to say, is the water drinkable or not? And part of that is you need a perspective. You need a use case to say, is this drinkable? What is the quality of this water? It's use case specific. And the use case we're utilizing is HEDIS, quality measurement. We're working with health plans and insurance companies that already exchange data to understand the quality of the data. So we're able to analyze and provide information to the government to say, hey, this data exchange is great, or this data exchange needs improvement because it's great for watering my lawn, but you shouldn't drink it.
Tell me more about the health plans and insurance companies that you're working with in the Bulk FHIR Quality Coalition.
Think of these as dance partners. We need a health system to work with an insurance company that they already work with. Pairing a health system in Boston with an insurance company in California doesn't work. We're looking for dance partners already required to exchange data. This Bulk FHIR Quality Coalition will help that data exchange be more efficient and productive. We are establishing these pairs and letting them dance and learning from the exchange of data.
And you said we're establishing these pairs. I think you mean PAIRS, as in duos.
Yes.
Not payers, PAYERS.
No, correct. We need a couple, one insurance company with one health system, and that creates dance partners. We're looking for organizations that already partner. The lawyers have already worked through legalities of exchanging data. They do it one way. We're trying to get them to do it a different way. They have existing relationships to exchange data. And we are encouraging the bulk FHIR exchange of data using the G10 endpoint. G10 is a reference to one of the CMS mandates that'll be more cost-effective and efficient and reduce burden.
If these data partners are already dancing together, why would they want the Bulk FHIR Quality Coalition to get involved with what they're already doing?
We're establishing a standard. So when a health plan is receiving data, it's all in the same format from different health systems. So Johns Hopkins, for example, Johns Hopkins is going to have relationships with different payers. Each of those payers may have their own data format they need. That's a burden on Johns Hopkins. Conversely, if you're, say, Cigna, and you're receiving data from Johns Hopkins, you're also receiving data from a whole series of different health systems. Having one format reduces complexity and burden.
And in that sense, we would be enhancing the pre-existing relationship between payers and providers, right?
Correct. And by enhancing this pre-existing relationship, the payers will receive more clinical data, and they'll be able to utilize clinical data to treat their beneficiaries. If you are at a health system or an insurance company, I would encourage you to reach out about the Bulk FHIR Quality Coalition. Please join the Bulk FHIR Quality Coalition.
We'll link to the Bulk FHIR Quality Coalition in the show notes. Is there anything else you'd like to say about digital transformation, Ed?
I am really excited about digital transformation. We have come a long way in the last even 36 months with the standardization of FHIR, with the digitalization of measures that will reduce burden, improve efficiency, improve care. I'm excited to see how these measures can get adopted to reduce cost. A way to think about FHIR is we need all the data in the same format. That means the same language, same units of measure, the same file format. And all of that facilitates the analysis of the data. By having standardization, you're going to open the doors for great advances.
Ed, you've given us a lot of great information here. How do you suggest people think about these topics so that it all makes sense?
The digital transformation of healthcare is necessary to deliver higher quality care, but that is dependent on high quality data and the ability to exchange and access the data. It starts with high quality data, making it accessible, interoperable, exchangeable. That is the foundation for being able to deliver digital healthcare transformation. Nothing in digital transformation in healthcare makes sense without high quality data exchange.
I think that's a good place to end it. Ed Yurcisin, Chief Technology Officer at NCQA, thank you for joining us on Quality Matters.
Thank you. It's been a pleasure.
Look in the show notes for links to the NCQA Digital Quality Hub, the Bulk FHIR Quality Coalition, and other resources that can help you navigate the digital quality transition. To learn about data-driven strategies and practical solutions for addressing health disparities in underserved communities, attend NCQA's Health Quality Forum, April 7th and 8th in Baltimore. Topics include virtual care, rural access, health equity, and maternal health. Register at ncqaforum.org. Thank you for listening to Quality Matters. If you enjoyed this episode, please rate this episode 5 stars. We'll see you next time.